Our next speaker is Jim Youssef, talking about the legal and malpractice ramifications of lateral surgery.
So I'm going to talk about legal stuff, and one of my disclosures, I'm not an attorney and I don't pretend to be one. But I think it's interesting. It was an interesting talk to prepare just because going through this, you realize that solicitation on the internet, on the highway, on the billboards is rampant. Attorneys are constantly looking for opportunities to get all of us and our patients into legal suits and looking for judgment against physicians or hospitals, implant manufacturers. And so I think it's a common issue, and as I kind of looked through it, I was like so surprised. But if you look at the JAMA article on the rates and characteristics of paid malpractice claims among U.S. specialists, there's 24 specialty categories and one other category with 280,000 claims. And the highest rate of paid malpractice claims was neurosurgery, and orthopedics was fifth highest. The malpractice payment amounts was highest for neurosurgery again, whereas in orthopedics it was sixth lowest. So there might be an advantage of being an orthopedic spine surgeon versus a neurosurgical spine surgeon. Complications obviously occur. We've talked a lot about these today, intraoperative, postoperative, and remote complications. And there are specific complications to lateral surgery, most of which are transient neurologic, which are unique to that approach. But the internet and social media drive patients to share their feedback. And this is the top 10 most popular physician rating sites, review sites, and I happened to just Google myself just to see what was going on some of these sites. And fortunately, I had some decent ratings, but it's amazing what happens when you start to look through this because we don't have any control. We have no control over what is posted, and it's really hard to actually monitor it and pull it down if you find a bad review. And oftentimes they're anonymous, and so you don't know where it's coming from. And the other thing is that patients talk to each other. And so there are chat rooms, this is on Spine Health, where one patient is asking another patient about the efficacy of an XLIF. And, the surgeon, is quite realistic, which is favorable. But what's interesting is that the choice between a PLIF or an XLIF is a no-brainer, in one of the comments. And it's interesting that the patient still isn't aware that it's a fusion procedure at the end. So, here's some, I think a little knowledge is dangerous. And so it's important for us as the obligatory physician providing the information to create an informed consent that provides the patient with information. And so if we look at the AMA's definition of Code of Medical Ethics opinion, informed consent to medical treatment is fundamental to both ethics and law. Patients have the right to receive information, ask questions about recommended treatment so they can make well-considered decisions about their care. And the process of informed consent occurs between two people, the patient and the physician, resulting in patient's authorization to undergo a specific medical intervention. The minimum elements of this have to include alternatives to that treatment. So if you are talking about doing a fusion surgery, I think it's important to say, you can go with non-operative care, and you need to document that, or further injections or further physical therapy. The other elements really, as we start to use more mid-levels or we have residents and fellows, we have to kind of commit to the fact that we disclose that to our patients, that in times, for the non-critical part of the case, there will be other people who are participating in that procedure. And so it begs the question, what is the standard of care? And so the standard of care is the degree of care expected of a minimally competent physician in the same specialty under the same circumstances. However, the standard of care can change with time, and if the standard of care isn't a malpractice suit, it has to be the standard of care at the time of the event, not something that's happening today for an event that was 2 or 3 years earlier. And this is an interesting article by Nancy Epstein. It basically says that recent legal decisions that testimony should be based upon scientific evidence. There have been some people who have lost their status in the AAOS for using non-evidence to support a case, a malpractice suit. And the scientific evidence indicates that there's oftentimes more than one standard of care. Thus, a specialty society has to be careful about the position statements it puts out there, because if it's not based on evidence or ignores the evidence, the risk of appearing or fostering self-interest at the expense of patient care is evident. So we need to be cognizant of how we position those statements. So what are the reasons for spine surgery malpractice claims? Well, in this particular Westlaw database, the descriptive analysis of federal and state surgery malpractice litigation in the United States, this looked at verdict and settlement reports pertaining to spine surgery. And there was 98 cases, and the number one reason was procedural error, followed by lack of informed consent, followed by failure to treat or failure to diagnose. And if you look at the medical legal landscape of how surgeons fare, obviously technical judgment, consent, wrong level surgery, all of these things kind of start to populate the list regardless of the anatomic region. And proportion of surgery that led to malpractice cases involving consent were higher with lumbar procedures, which, once again, you start to wonder, based on that conversation I showed you earlier, patients may not really understand it. It might be more complex. It might be difficult for them to comprehend. And I think it's important that you bring it down to layman's terms for them to understand the procedure. If you look at this review of neurosurgery medical malpractice claims in the United States, the chief medical factor resulting in malpractice neurosurgery physicians in terms of percentage of closed claims paid was the wrong patient or wrong body part. And if you think about that with the spine, that's almost difficult to understand, but getting an intraoperative x-ray, confirming it, and putting it in the medical record, documenting it in your note, I think is really important. Procedure that was performed or not indicated or contraindicated, or delay in performance or failure to recognize a complication. Treatment-associated damages to review cases that were deemed justified. These were mostly due to procedural, followed by post-operative care. So, I'm sure all of us here in the audience have been to meetings, we've operated, we've had to leave, we've left that care in the hands of another physician, and sometimes that physician may not be capable or may not have enough supervision to provide oversight. And so it's important that you guys recognize that's a big liability for us. Conditions and procedures that are associated with malpractice claims, fusion is about 31% of the listed procedures, followed by, and in this particular paper, it was 40% of the lumbar procedures. But if you look at the most prevalent presenting medical conditions resulting in malpractice claims, it was actually discectomies and laminectomies. And so it's the simple stuff that leads to a bigger problem. For whatever reason, dural tears, those seem to be at the very high of the list, even though they're oftentimes asymptomatic after they're repaired. And I'm not sure that even an incidental durotomy seemed to be a higher list of malpractice claims, even if they were repaired and there was no sequela for the patient. So I think what happened is that we've somehow communicated that a dural tear is a catastrophic event, whereas it's really just like a transpsoas approach, kind of just like thigh pain or transient thigh pain. It can just be a temporary issue. I think it has to do with how we communicate. This is just in terms of closed claims versus claims paid. The most prevalent spinal operations, once again, laminectomy and discectomy. But there is some good news, so this is not all bad news. The good news is that outcomes of litigation tend to go in favor of the defendant or settlement in most of the cases, and less often to the plaintiff. And this is across all of the regions of the spine. Same here. This is in terms of breaking it down into laminectomy or foraminotomy. In terms of outcomes of closed claims, they're pretty low. So if we talk about medical malpractice, the elements that are required for a patient to bring suit in the United States are professional duty owed by the patient, a breach of such duty, injury caused by the breach, resulting damages, breach stem from a deviation of standard of care when a licensed healthcare provider is targeted. Medical error is defined as a failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. Medical malpractice is a physician failing to act as any reasonable physician would have acted under the same circumstances. So unsuccessful surgery does not necessarily mean a breach of standard of care. Inappropriate decisions that lead to litigation include inappropriate delegation to junior physicians. So if you feel like your fellow is capable of doing a lateral and they've only seen one, not done one, and you've left the room and there's a catastrophic injury, I think that's a problem. Lack of expertise. So if you have gone through the training and you don't really have not done that many cases, or maybe one or two, I think it's your obligation to disclose that to the patient. And if you need help, you call for help. Failure to recognize the clinical signs and symptoms of complications, inappropriate patient selection, inappropriate preoperative evaluation. But if you document and you provide good clinical care, and the informed consent process will oftentimes discourage plaintiff attorneys from accepting these cases, because it's nice if you have good documentation that demonstrates the communication. It captures that event. It captures that communication between the patient. But poor documentation is just a nightmare for you, because it just sets you up. You might as well just get your checkbook out, because at the end of the day, if you don't have documentation, you're kind of in a bad situation. The other issue is diagnosis of complications. So delaying your diagnosis of a complication. Oh, the patient's going to get better. Oh, the patient's, I've had a couple of junior partners, and, just simple things like a persistent neurologic deficit or persistent neurologic pain, radiculopathy. I think we're obligated to look. And unfortunately, when we look, we see stuff that we sometimes don't know how to really deal with. But at least it shows that you made some attempt to identify the problem. And you may do nothing, but you also may find something that requires a change, a psoas hematoma, an epidural hematoma, something that causes you to make a different path in your decision and your judgment. And I think it's important that you do not delay that diagnosis and put your head in the sand. Now, more good news, tort reform. The record payout from a broken malpractice system is $135 million, okay? And this was a largest single payout to a patient for medical malpractice in a spine case. It was a 10-year-old girl who underwent a scoliosis fusion, experienced pain and neurologic dysfunction. Another surgeon removed the implants 10 days later, and the patient was non-ambulatory for a year and was left with persistent incontinence. So tort is either an omission or an act that harms or injures another person. It's a civil wrong. Medical harm can include medical expenses from payment for pain and suffering, loss of income, loss of future income, loss of one or more body parts. Tort reform is changing that civil justice system to reduce both the ability of victims to litigate and the damages they can receive if they choose to litigate and do so successfully. So if you survey physicians, they say, well, what is the top reasons to discourage lawsuits? And one of them is better communication, having a medical panel to screen for merit, placing caps on non-economic damages, making the plaintiffs responsible for costs. And states that have imposed caps on pain and suffering are listed here. This is 2016 data, but it's starting to tip across the United States. And this is a great example in Texas of what happens after you have tort reform. I mean, the number of cases that were brought for suit dropped precipitously and stayed the same over a 3-year period. So it works, it's just that trial lawyers, they donate a lot of money for lobbying efforts. I mean, if you look at the numbers, I was trying to find a slide that showed the difference, but it's like 15-fold of what doctors contribute to PACs and what trial lawyers contribute to a PAC system. So they're very powerful in terms of fighting this. It comes up in Colorado almost every year. We just voted on it again. And the other thing that's interesting is this next flavor of tort reform, which is called affidavits of merit in medical practice. It's signed by an expert in the field attesting to the merits or the merit of the claim, and it's a product of tort reform efforts. The benefits are that you have a panel or you have a physician or a group of physicians that look at this and then decide, is this thing worthy of bringing it any further? And so there has to be, at least it provides you as the treating physician some benefit that indeed there's another colleague looking at this objectively and saying whether or not this case is actually valuable. It limits the types and amounts of insurance that can happen. It also reduces the number of frivolous claims and the number of types of decisions made out of professional judgment, but rather a fear of lawsuits. So we end up with, reducing defensive medicine and wasting dollars as well in states that have these kinds of situations available. And they're growing. I mean, this is 2018 data, but it's basically showing, it's kind of following what's happening with tort reform. Unfortunately, when I was asked to give this talk, it was specifically on the number of complications, or sorry, legal ramifications or published research on malpractice and lateral surgery, but I couldn't find anything published. I did ask my own malpractice carrier in terms of like how many cases they've seen, because they cover a lot of states, and they found 8 cases, 5 laterals, and fortunately, almost all of them were dismissed, which was great. And I think in conclusion, like there was nothing specific to lateral that I could find. However, I think the important factors in avoiding a medical malpractice lawsuit include good clinical care, good communication with your patients, proper patient selection, appropriate informed consent, thoughtful and timely documentation, and prompt diagnosis of complications and treatment and referral. If you can't treat it, I mean, feel free to refer to someone who can treat it, but do it in an expeditious fashion. Don't send the patient home. Find someone, and then, it's just go ahead and transfer them from the hospital if you don't feel like you have the ability to do so. Thank you very much.